Hey. Okay. Yep, you're good. All right, everyone. I greatly apologize for the quite a bit of technical difficulties here getting all this going. I'm hoping that everything is now in working order and everyone can hear me. So I'd just like to introduce myself. My name is Aaron Gebrelul. I'm one of the orthopedic surgeons at the Anderson Orthopedic Clinic. As you can probably guess from the talk, hip and knee replacements. How do I know when it's time? My clinical practice is exactly that. It's focusing on the both the non-surgical and surgical management of people who have hip and knee problems, typically as they age. My practice is not as much as the younger athletes who tear their ACLs, as much as it's more about elderly patients who have hip and knee arthritis. So there's a lot that goes into the decision for surgery. And I think it's a very nuanced, complex discussion that there's no way I could go over all the details in the next 30 to 45 minutes, but to at least get an overview of what the problem is and how we manage it. Hip and knee osteoarthritis is one of the most commonly diagnosed medical conditions in the United States. So very briefly about myself, I think probably my journey begins on a different map, as my parents are from East Africa, a country named Eritrea, but they did immigrate to the United States, and my journey here is a bit more local compared to Africa, but not compared to Northern Virginia. It's the most southern point on this map. I was born and raised in Baton Rouge, Louisiana, so this is my favorite time of the year, as football is right around the corner. My next stop in my journey is a bit north in St. Louis, where I went to Washington University in St. Louis for my undergraduate education. I then ventured a little southeast to Atlanta for Emory University School of Medicine for my medical training, and then over west to Dallas for my orthopedic surgery residency training. And then I made one last quick stop in the University of Pennsylvania in Philadelphia, where I subspecialized in, of course, hip and knee replacements, or otherwise known as adult reconstruction. So, there's a lot I tell my patients about my job that is complicated, that takes years of training to understand. But there's other parts of my job that, quite frankly, I think are obvious to anyone who has eyes. And I tell people in joking that, it doesn't take all this money I got overcharged in medical school to see when someone's hip is in really bad shape on x-ray. And this is what I want to demonstrate to you. If you look on the left x-ray, that's a relatively normal hip, on both sides. When I say normal, the easiest thing to point out is really the space between the ball and the socket of your hip joint. Space on x-ray is a good thing. That means you still have healthy cartilage, and it means that there's probably still some life left in that joint. The problem is what you see on the right side, where that space is completely obliterated, and you can see the bone looks really white and angry, and these are all just different radiographic signs of what we call end-stage osteoarthritis. And of course, what applies to the hip, that same concept to the knee. And like I said, it's not, when it's obvious, it's obvious. It's not anything that requires a discerning eye as much as it is me pointing out what space looks like and what space doesn't look like. So the easiest way to really conceptualize and think about osteoarthritis is I just call it, it's the wear and tear, loss of that cartilage cushion between bones. And osteoarthritis can be any joint in the body can have wear and tear. Obviously, the hips and knees are two of the most common, but of course, shoulder, elbow, and even those small joints in the foot and the hand can get arthritis. And I like to kind of give analogies when I discuss this with my patients. And the first thing I mention is think about the tires or the tread on a tire, right? When you get a tire fresh off of the lot with a brand new car, your tire looks like what you see on the left side, but the more you drive that tire, you're going to wear that tread thin and you're going to lose that cushion. And that's essentially what's happening with osteoarthritis. Now, it is very common. I always tell people that the itis, whenever you hear that in medicine, means inflammation, right? So, appendicitis, tendonitis, bursitis, it all means inflammation of whatever's preceding it. And that's part of the process of arthritis, is that you can have arthritis from, rheumatoid arthritis, you can have septic arthritis from bacterial infections. But this talk is really focused on the most common osteoarthritis, which is the wear and tear. And it is not a reversible condition. No one's knee x-ray, just to go back, goes from the right to the left. Now it can go from the left to the right, but you can imagine tread doesn't magically grow back on that tire. You got to change the tire or retread that tire. And I hear a lot of people mention things like regenerative medicine, and I just caution people on really digging deep on what that means. If they're told by another provider, oh, I can give you a regenerative medicine, this type of injection, really be a little discerning, because I think there's a lot of misinformation on what that really means, because there is no cure for osteoarthritis short of a joint replacement, and we'll get to that in the future. So I always tell people, osteoarthritis, wear and tear, is the disease of people who've been on the planet walking around for decades, right? There's a expression in sports, if any of you guys are sports fans, that father time is undefeated, meaning no matter how well Tom Brady looks in his 40s, at some point, father time catches up. Now, I wouldn't say necessarily that exact same concept holds for knees and hips, meaning everyone's going to have arthritis that'll need surgery at some point. But just to illustrate the concept of, the older you are, and as our population is healthier and ages longer, we're seeing this more and more. And the amount of joint replacements we're doing is really growing. It is something that we see more often in women than men. I put obesity doesn't help. Not that necessarily obesity is a cause, but when you put more stress on your joints because you're packing more weight, it will cause maybe what would be mild symptoms to be more severe, even if, let's say, the x-ray isn't significantly different. History of joint injury is a big component. We typically add a qualifier before the osteoarthritis when we're discussing those conditions, and we call it post-traumatic osteoarthritis. And I see this oftentimes in people who maybe tore their ACL playing college sports, and now 30 years later, that knee's worn down. A lot of people have falls and car accidents and have fractures around the joint. And what happens is your joint never really goes back to how it was before the injury. And years of loading and using and cycling that joint just causes it to wear away sooner than it would have if you never had that ACL rupture, for example. So that's a special type of osteoarthritis, but still in the general bucket of a wear and tear condition, in my opinion. Now, the symptoms, I think, would be familiar to a lot of people who maybe have this or maybe have a family member. Of course, it starts with pain, right? When you lose that cushion between the bones of the joint, of course, you're going to have some mechanical symptoms. You're going to have pain. Also, because, as I mentioned, the itis, inflammation, when you start wearing away that cartilage between the bones, your body starts sensing, something's going on with my knee or my hip. And it really sends the same type of painful inflammation cells that it sends if any of you guys get a bug bite or a mosquito bite in the summertime and you look back at your wrists and you see a big red wheal. It's painful, it's red, it's tender. And it's kind of what's going on inside your joint, like you're having a bad bug bite. And that's why it's going to cause things like stiffness and swelling. And people say my knee's blown up and I didn't even do anything. You can imagine as you lose that cushion, people say their knees are more noisy. Their hips are making noise. It's crunching, it's popping. And there's a medical term for that we call crepitus. As it gets worse, people go from having mild symptoms to now they're having a limp. The things I mentioned in the right column are kind of more severe, unsteadiness with the gait. Used to be okay by yourself. Now you're using a cane, maybe a walker, maybe a rollator. And these issues do cause significant issues. This osteoarthritis can cause significant issues at night when it comes to sleeping and getting good restorative rest. And those are things that usually get a lot better once the arthritis is better managed. Now, the diagnosis is really straightforward, at least from an x-ray standpoint. And as orthopedic surgeons, x-rays are like our oxygen. We use it all the time, and it's really important, and it's a key clinical step. Now, I have patients all the time that either come with MRIs, they come with CT scans, or I have patients that request it. The reality of the situation is once you start having really arthritic changes, not necessarily the complete bone on bone, but once it's really that joint space is getting thin, you're starting to get the bone spurs and all the other signs of arthritis on x-ray. Oftentimes, there's not much that the MRI adds. Now, I do order them if I'm looking for something specific. I had a patient the other day that I was concerned was there some loose body in his knee, and that was a good reason to get an MRI and then to evaluate some of the other structures. But for the typical case, all we need is for you to come to our office. We have x-ray set up here. And at that point, I'll be able to probably answer all your questions about your diagnosis. And of course, the outlier cases, which are less typical, sure, those will be the times where we maybe get some blood work, check some labs, maybe get an MRI, maybe a CT scan. But I would say that's a really small percentage, even if a lot of people get them from other sources. Now, let's kind of get into more of the meat and potatoes, I would say, of the talk here. Okay, you come, you see me, you see one of my partners, you see a doctor, a PA, anyone from anywhere. They get an x-ray and they say, oh, well, this pain that you came with, it's because you have some hip or knee osteoarthritis. And that's what the OA in subsequent slides is going to stand for. Now, I did kind of make it seem like it's a kind of a dichotomy of you either have osteoarthritis or you don't, but it really is a spectrum, right? Back to that tire analogy, it doesn't go from thick treads to bald overnight. It's really over time. You go from really thick treaded to not as great, but still pretty functional, and then eventually you get to that bald tire. Same thing with hip and knee osteoarthritis. We have different grading systems. For hips, it goes out of 3, so that bone-on-bone hip is a grade 3. Knees, it goes to 4, so a bone-on-bone knee is 4. But I see a lot of people at various stages, and of course, the more advanced the stage, typically that's the patients where they have more symptoms, more pain, and it looks like we're more talking about surgery being more in their immediate future as opposed to someone that comes with more mild arthritis. But to be clear, I tell people all the time, because you have arthritis does not mean it's time to look at my surgery schedule and get on for next week, okay? The short answer is no, the long answer is no. The important thing to really remember is that hip and knee replacements are a elective surgery. And there's a couple things that I want to get into as we progress. So I have seen people who have gotten CT scans of their abdomen or things of that nature. They read their report that just happened to scan the very top of their hips, and it says, mild to moderate hip osteoarthritis. They see them in the office a little concerned, saying, oh, I didn't know I have arthritis. What do I do about it? Well, the first thing I ask them is, does it hurt? Are you having any symptoms? And oftentimes they say, no, I didn't even know I had it. Well, that just means you have some type of imaging that says you have a little bit of narrowing of your joint space, you have some bone spurs, things of that nature. But quite frankly, a lot of people are walking around every day with some wear and tear arthritis, even severe, and they don't really have severe pain and symptoms, right? And again, I always tell people I'm in the quality of life and the pain reduction business. I don't treat x-rays, I treat people. So if you come and say, hey, I've been told I have arthritis, and I say, well, how bad's your hip? And you say, well, it bothers me once every few months, but other than that, I feel great. I pretty much say, hey, call me when you need me. The other thing that I do here is what I put in quotes is prophylactic surgery, meaning, well, Dr. G, you're telling me I got a lot of hip and knee arthritis. I'm 61. I'm not getting any younger. Let's just go ahead and get it done because I'll need it anyways. That's definitely a strategy that I recommend against for a few reasons. Number one, if you look at some of the studies that assess how bad the arthritis, how bad your pain is before surgery, it really is the outcomes are related to the symptoms prior. And that means is if you have legit pain, if it's really affecting you, if your quality of life is not what you need it to be, great indication for surgery. There's a very good chance surgery is going to make you a lot better. If you do surgery because you say, hey, I'm probably going to need this, then you got to worry about you may not have the outcome you want. And the example I give is if someone comes to me with knee arthritis, not very much knee pain, and says, well, let me just get it out of the way. Well, my concern is what if I do a knee replacement with someone who doesn't have much pain and unfortunately there's a complication or their knee is a little bit stiffer than they want? They're not going to be happy. They're going to want their old knee back. So it's not about getting it done because I'll need it anyways. You do it when it's the right time. And again, that's kind of the central theme of this talk, and I'll get into more of that in the future slides. The other thing is both ends of the spectrum. It's the too old and the too young for surgery. I'll address the too old first. Of course, as we age, our body is not as resilient and able to bounce back from anesthesia and big surgeries and things of that nature. But age, I think, is just one variable. And I always tell people it's not age, it's about fitness, it's about health. I've met plenty of people in their 40s, 50s, early 60s, right, who are relatively younger for joint replacements that I wouldn't touch with a 10-foot scalpel. They're obese, they're smokers, poorly controlled diabetics. And I've done hip and knee replacements on people in their 90s. I have one patient I think in my mind who's 92, who I'm jealous of. I think she walks more than I do and is in better shape than me. That's not someone who's too old for surgery. You take every person individually. And of course, the other end of the spectrum is the people who unfortunately maybe they tore their ACL. These are typically the post-traumatic cases that have really advanced disease at a young age. And traditionally, the way we would think about that is, hey, you just have to find a way to live with that painful knee or that painful hip until you become 65. Then it's time for surgery. I think that is, we are shifting in our thought process there. And again, I would say if you're 25, yes, that's probably in the too young range. But, when you're in the upper 30s, 40s, if you have a really bad x-ray, you have severe symptoms, it's greatly affecting your quality of life, it's worth having a discussion about what it means to have a knee replacement at 48 as opposed to 65. And the way I think about it is, sure, the ideal situation is we do one knee replacement, one hip replacement that lasts the rest of your life. And obviously, the younger we do them, the less likely that's to happen. But I tell patients who are, let's say, 45, if I can get you 15, 20 years of great quality of life with this knee replacement, and when you're 65, we have to go back in and maybe redo it, would that be something that you'd be happy with? And usually it's a unanimous yes. I want to be able to enjoy my life while I can, because no matter how successful we are, how happy we are, the one thing we can never buy back is time. So when I tell people they never need to have a knee replacement, you don't have to have a knee replacement. It's centered on these are elective surgeries. But the really important thing in my office, I don't write a lot of things down, but I always mention what people comment about their quality of life, what activities they like to do, what are they not doing because of their knee or their hip, what do they want to get back into doing. And quality of life is really an independent, individual analysis. I can't judge anyone's quality of life for them. Of course, as a surgeon, as someone who's knowledgeable in this field, I can help answer questions. But this gentleman on the bottom left, I have patients where if they can't, walk the golf course, if they can't, do the participate in that activity with their buddies, which they were so looking forward to once they hit retirement, they're not happy. And I have other people that say, well, you know what, I was going to golf, but quite frankly, I picked up other activities and I'm okay that I can't do that. Those are two people who view the changing of activities differently. Of course, nowadays, I think if I got $1 for every pickleball player, I probably wouldn't have to work as much, because that's the new craze. And a lot of patients, they're not going to be happy if they can't at least get back on the pickleball court, not just for the activities, but for the community, for the camaraderie. And quite frankly, I also have patients that say, I just want to get back to walking with my grandson. I just want to get back to spending quality of time without being in pain. I'm tired of being the person that's holding back everyone when we go on our vacations and they're waiting for me. I don't portend to want to get back to playing pickleball or running, but I just need to be able to walk with my family without having this pain and swelling. So again, these are 3 different cases, and it's 3 different individuals. They could have the exact same x-ray, and we can end up with 3 different treatment options, because like I said, it's really a conversation and a personalized approach to what's best for you and your needs. Now, this is a picture of me in the operating room to the left. I had some animation that didn't translate great, but I want to tell people we are surgeons. Obviously, we enjoy doing surgery. We do things that we believe can really help patients. But the first step is to say, hey, can I get this patient better without surgery, right? I tell people my job is not to fill my OR schedule. My job is to help patients get better. And a lot of what we can do has a lot less risk of surgery. So if I have a patient getting on a stationary bike 30 minutes a day and I don't see her back in the office because frankly she doesn't need me, I'm a happy man. I just made someone better. And what I mean by what we try first is the easy stuff, right? If someone has hip or knee arthritis, especially when it's early on, especially when you first start having symptoms, don't rush to the operating room. Don't let a surgeon that you meet for the first time because he had 2 weeks of knee pain tell you you need a knee replacement, because you don't. What you need is to see what you can get from physical therapy, low impact aerobic exercises. I am a big time proponent of stationary biking. I have a lot of patients out there that have a recumbent bike that they got from Walmart for $150, free setup and delivery, sitting in their basement. They wake up, they have their breakfast, they do their 30 minutes on the bike, and they feel good for the rest of the day. And those patients, like I said, I often don't see them as much as I'd like to because they don't make appointments when their knee's not hurting. And this is something that is really not hard to do, but it acts to strengthen the muscles around the knee, because as the knee is wearing away, it puts extra emphasis on making sure you're in good shape. Back to my car and my tire analogy. Think about you as a human car that needs to walk around and move. If you have a tire that doesn't have the best tread left, but you really take care of all the other aspects of the car, then you can really function well. And you can really not notice that that tire's running a little thin on tread. But the problem is if you have a little tire issue and then you just keep that car in the garage for 3 months, you don't move it, you don't drive it, right? You don't exercise, then what sets in is the weakness. And weakness is a hard problem to address quickly, because that's going to cause a lot more pain. And it's a cycle of, I don't use my knee, it gets weak, it hurts more. So I don't use it anymore, it hurts more. And it just kind of goes around in a circle. So it's really important to make sure that you are staying active. And of course, this applies to hips as well. Now, weight loss is not going to cure your x-ray. If you drop 50 pounds, it's not going to make your cartilage become thicker. But like I said, if you got a lot of extra baggage in the trunk, it's going to be harder to move that car. And there's a lot of studies that look at the amount of force that goes through hips and knees per pound that you gain. I believe in the knees is about almost 5 to 7 pounds of force for every pound that you gain in body weight. So it really makes a big difference. Now back to the itis of arthritis, the inflammation, right? NSAIDs means non-steroidal anti-inflammatory drugs. So it stands to reason that that is the mainstay of the medical treatment or the medication treatment for osteoarthritis, inflammation. So these include the over-the-counter Advil, the Aleve, Motrin, ibuprofen, whatever it goes by. And of course, there's a slew of the prescription variety: meloxicam or Mobic, diclofenac, Voltaren, Celebrex or celecoxib. These are really, I would say, for the people that do what I do, that's probably by far the most common medications we prescribe are anti-inflammatories. Now, turmeric is a spice, kind of more of a natural occurring, I guess it's just a spice that actually does have quite a bit of anti-inflammatory properties. And there was a study that looked at that versus some of the more conventional anti-inflammatories, and it did hold up as relatively equivalent. Now, there are some patients that can't take these NSAIDs, typically people who have chronic kidney disease or have really bad stomach issues, ulcers, gastritis. So my first line is always the anti-inflammatories. If they can't take that, then I recommend turmeric over the counter, sprinkle it on your rice. And then lastly, there's some data that tramadol, which is a weak opioid or narcotic pain medicine, it is regulated as such that also can be used for people that can't take anti-inflammatories, although I really don't use this much except for post-operative pain, but not really in the pre-op setting. And of course, everyone knows you can get all types of creams, gels over the knee, and there's a lot of different injections. I am a believer in the tried and true steroid or the cortisone shot. I think that has a long track record of being very effective, and it's also cheap and easy to do in the office. And of course, the quote-unquote gel injection is hyaluronic acid, which I think has better studies and efficacy when you look at the knee versus the hip. But I think these things can be very helpful. Again, the whole point of these is not to cure the arthritis, but is to hopefully help the pain so that you can really get a lot of benefit from the exercise, from the therapy, because that's what's really long lasting as far as how you're going to do 5 months, 6 months, 2 years. It's really staying in shape and keeping active. So I get this. Hey, Dr. J, I tried all of that. My knee, my hip still hurts. I guess, time to sign up for surgery now. And at this point, I kind of have a talk that I give patients. I am very careful with some of the words I use in the office because I don't want people to get the wrong impression. And one thing I emphasize to patients is I never say, hey, you need a knee replacement. You have to have a knee replacement, because this is very different than, the other life-saving type of surgeries that really are something that you should have because, there's a lot of serious medical conditions out there. It's not one of them. So what I tell people is not you need one, but hey, you're a candidate for one. And what I mean by you're a candidate is really these kind of 4 criteria that I've outlined here. So the first question obviously is, do you have the disease? Do you have arthritis? Just because you're coming with hip pain doesn't mean the ball and socket hip joint, which is all we do with the hip replacement, is the source. I see a lot of people who have hip pain. I look at their x-rays and their x-rays look better than mine. I talk to them, I dig deep, and it really seems to be coming more, let's say, from the back. Maybe a pinched nerve, maybe an SI joint. Maybe this is a strained muscle. Maybe it's a pulled tendon. Things like that nature. Just because you have hip pain doesn't mean you're going to need a hip replacement. You got to have the arthritis, and preferably it should be bone on bone. So obviously that's the first step, and I kind of evaluate that before I even walk into the patient room because I can see the x-rays in the office before I walk in. Now, the next one is, well, what have you done? Everyone is different in their presentation. Someone who comes in with the x-ray you see to the left, which is really advanced, but says, quite frankly, I've been doing great up until 2 weeks ago. That's someone who, even if they're bone on bone, 2 weeks of pain doesn't get you a hip replacement in my office. What it gets you is a therapy prescription, an exercise program, potentially, like I said, that anti-inflammatory if you can take it. And I have partners that do my hip injections for me. And of course, I can do the knee injections myself in the office. Now, the next question is, okay, you have the disease. What have you done for it? And if a patient says, yep, I've been getting injections every 3 months since the Obama administration, I'm taking ibuprofen like Skittles, nothing's working. And that's a very different next step than someone who says, oh, this popped up 2 weeks ago and I haven't really done anything. Now, once we get to that, it's, hey, what is this knee or hip doing to you? Right? Is it greatly affecting your quality of life? Not how many days of a month do you have pain? Not are you still able to do certain activities? But you tell me, how do you view your life? How do you view what you want to do? And is the knee or hip impacting that? Now, a lot of people, have other medical conditions that keep them less active than they want. And it really might not just be the knee and hip. But when the hip or the knee is the driving force behind the statement of, I don't have quality of life, then you've crossed that off of my checklist. And kind of the final one is, of course, we're doing surgery. And like I said, it is an elective surgery. And surgery at its core, especially major surgeries like this, do have their fair amount of risks and chances of complications, right? Therefore, are you morbidly obese? Are you a smoker? Do you have poorly controlled diabetes? Are you alcoholic? Do you have quadruple bypass and your cardiologist says you can't go? There's a lot of things that go into, are you healthy enough for surgery? And I would say a lot of times this is a decision that I don't make solo, but in conjunction with their primary care, with the pre-op clinic, with the anesthesiologist at the hospital or the surgery center to evaluate a patient and say, hey, is this safe? Usually I have pretty much all the say in the first three, and then I have to rely on some colleagues on this last one. Now, let's say we went through that checklist and it's clear. This person that's in front of me is definitely a candidate for a knee or hip replacement. What I typically do in those instances, I kind of jokingly back out of my chair and say, the ball's in your court. And what I mean by that is both if and when are no longer, in my opinion, this shared decision-making. It's really completely up to you. If I say you're a candidate for a knee replacement, if I go through the surgery, if I tell you the risks, the benefits, and you hear all that and you say, hey, Dr. G, thank you for this, but I'm not interested right now, and that's the end of the discussion. Versus if I go through all that and you say, you know what, I think I'm ready, then obviously that's a different set of circumstances. Also, if you say, and I'll get to this a little bit more in upcoming slides, if you make that decision, well, yeah, I think I'm ready, I think I want this done, then the win is also completely up to you. Now, of course, if you say, my next available, then I have to give you a little bit of feedback there. But otherwise, if you say, yep, I wanted to get through my summer and have something done in November, I say, great, let's look at the schedule. Now, there are a few things that I want to specifically point out that are a little bit of asterisks on this whole balls in your court thing. Number one is when I have patients mention, yes, my knee and my hip is so bad that now I'm falling. And again, a lot of my patients are elderly. They may have osteoporosis. That's one reason where I will maybe gently nudge them into maybe getting something done sooner rather than later, because all it takes is one bad fall to break your hip, break your wrist, break your spine, and that can cause a lot more issues. When patients go from being able to walk by themselves with no issues, and now they're on a cane, now they're on a walker, now they're on a rollator, I can see their activity and I can see their debility getting worse. The surgeon in me, when I think I have a solution to make that better, I do get a little bit more aggressive in saying, hold on now, I don't want you to end up in a wheelchair. Let's stop this progression. Of course, the other kind of related thing to that is if it's so bad that you're not exercising, that now you're gaining weight, now that's causing your diabetes to be a little bit worse and it's causing your blood pressure to get worse, then now your knee is not just affecting your pain and function, but it's actually affecting other medical problems that can have serious consequences. Now, speaking more specifically on the knees and the hip front, so I see a lot of people, every few months, every 6 months, checking in on them. Maybe they want an injection, see how they're doing, get some new x-rays. The thing that concerns me is when I document their motion, their flexibility in the knee, and it's getting worse pretty soon. There's certain things that we just can't fix, at least as reliably, with knee replacements, and that's the really, really stiff knee. If I take someone who's 0 to 140 degrees, really flexible, I have a lot of confidence that she's or he's going to be able to get that back after surgery. But the stiffer you are and the longer you're stiff, the harder it is to get that motion back. So that's another one that I'll judge. And I won't go into the details about this, but There are different types of knee replacements, what we call a partial versus a total. The partial is basically if you only have arthritis in one area. And sometimes if you wait, you kind of miss the boat on being a candidate for a partial knee replacement because the arthritis is spread, and it might have been a better idea to maybe get that done early, really protect the knee, balance it well to hopefully mitigate the potential of having to have the full knee replacement down the line. Now, the hips, we do see kind of rapidly progressive disease more often in the hips than the knees. That's for osteoarthritis as well as avascular necrosis, which is a separate diagnosis. But when I see someone where I'm looking at x-rays over 3-6 months and it's looking like 10 years have went past, I will say, hey, we might want to get something done sooner rather than later. And there is a lot of correlation between the hip and the back. And if I have someone who's really, because their hips, they're crunching, they're leaning forward, they're putting stress on their back, and now their sciatica is flaring up, that's another reason why I tell people, hey, you can get 2 for 1 with this hip replacement. It can help your hips and your back. And a lot of times you do a good hip replacement, they straighten up, they walk normal. The next thing they say is, I don't even need to get back injections anymore. Now, this is an article that I just wanted to mention the title because I think it's a really important point, and it's one of the things that I want to get across that I want all of you guys to be equipped and knowledgeable about if you ever kind of traverse this path here. And you can see the name of this is The Crux of the Issue. Assessment of patient appropriateness for joint replacement requires a conversation with the patient. It seems very simple, but the reality is, and for good reasons, a lot of us have really busy schedules. We have to see a lot of people in a short amount of time, and we can be a little bit short, but this is not the patient encounter to be short. Maybe the patient that's doing awesome, 4 weeks after a hip replacement, you high five and you say, I'll see you in a few months. But this is a time to really sit down and not be that scary surgeon on the left that wants to put on his gloves and operate, but be that empathic doctor on the right that takes a seat and talks to patients. Because like I said, this is not a simple algorithm. You go here, yep, surgery. It really is a deep discussion about what your goals are and how it can help you achieve those goals. These are just other articles that look at this because I really think this is an interesting topic about, how you decide when to have a knee replacement. So this one you can see, you'll know when you're ready, a qualitative study exploring how patients decide when the time is right for joint replacement. And this other one says the relationship between patient-reported readiness for total knee arthroplasty and the likelihood of a good outcome. Now that's something that I think the title is very powerful. I get into some of this a little bit later, but the crux of the matter is we can look at this, we can research it, but it all goes back to this. We have to converse about what's best for you. Now, I think about 3 different aspects that weigh into the decision to quote unquote pull that trigger for surgery. So the first one is the physical side, right? Now I describe surgery as a marathon. And I always have a joke in my office. No one yawns and wakes up, says, I feel like running 26.2 miles today. No. They prepare, they train, they optimize themselves. And that's what I mean by the physical side. It's, okay, what medical problems do you have? And can we make those medical problems better so that you're safer for surgery? Again, diabetes is just a quick, easy example. If that A1C number is a little bit too high, hey, you don't need to have surgery next week. Let's recheck, see how you do after 3 months, because the lower that number is, the safer, right? That goes for heart conditions, that goes for all types of kidney issues. Is, hey, what we can do to optimize it. The next point is what we call, prehab or prehabilitation. There's certain people I see in the office that have really advanced disease, really bad knees or hips, but they're in a wheelchair or walker and they just haven't exercised in years. And a lot of times I worry about their ability to recover from surgery because, like I'll get into, these are active recoveries. These are surgeries where you don't just have surgery, sit in bed, and 3 months later you pop up, moving and cruising. You're up really working with a therapist immediately. So if you're really weak, if you're really deconditioned, these are patients that I say, hey, let's do therapy for 3 months. Let's get on a bike for 3 months. Let me check you back. Let's make sure you're in better shape to run this marathon. A lot of people, especially nowadays with some of the new agents out on the market, come to me and say, hey, I know I need a knee replacement, but I want to just kind of get my weight down so it's easier for me. And I say, fantastic. Nutrition, specifically, we look at things like the protein status, your iron status, things of that nature. Oftentimes people do have nutritional deficiencies without even knowing it. And if we can, I say, let's fix it before surgery, right? Smoking, it's really behooves you. If you want to have a good outcome, you don't want to smoke. The risk of a complication is much higher. Same goes for people on chronic pain medicine. So when I see these patients, I try to come up with a plan and a strategy to help them kind of slowly get off of these things, whether it's working through their PCP, referring them to different pain management specialists that focus on other ways of treating pain besides opioid narcotics, because the less you're on before, the better your outcome will be. The next side, of course, is the mental side. Now, like I mentioned, especially then this goes to knees. They are hard work. I tell people very clearly, the biggest determiner of the outcome of a knee replacement is more you than me. So when I have a patient that sees me 4 weeks, 4 months post-op, oh, Dr. J, I love my knee. You're awesome. The first thing I say, and I'm not trying to be humble, is you got to thank yourself, because I wasn't the one pushing through those painful days with therapy. I wasn't the one who was having issues sleeping at night because you worked so hard that your knee's kind of on fire. And that's the realities. I tell people surgery's kind of taking a step back to take hopefully 5, 10, 20 steps forward in the future. But just because you're in good shape, you have to be ready up here to, yep, I am going to rock this recovery. And it is no surprise when I have patients that have great motion early on, it's because they took their rehab very seriously and they were mentally engaged every step along the way. And this is one of the conclusions from the articles I put before, is among patients who underwent TK, means total knee arthroplasty, so knee replacements, for knee osteoarthritis, patients' psychological readiness for total knee replacement and willingness to undergo total knee replacements were associated with greater likelihood of a good outcome. So even if you're in great shape, even if you can run a marathon in your sleep, if you don't mentally prepare yourself for this recovery, then you're not going to have the optimal outcome. And of course, the kind of last thing is the social side, the social support, right? Because emphasizing these are elective surgeries, meaning whether you have it done in the summer, spring, winter, fall, whether you have it done on a Tuesday, Thursday, all of those things don't matter. But if there's a month that works better because your son is coming home from college and maybe they can keep an eye on you, or hey, it's a really slow time of year at work in September, I can take more time, I'm going to do it there. There's a lot of things that goes into it because people work, people have jobs. Not everyone is retired when they have hip and knee replacements, and they need to work around those schedules. They need to work around family members. And I tell people, hey, don't rush and get it done when you don't feel as if you have the help and support, because having that family there is really important. Now, I do caveat when I see family members with their patients and I send them home after surgery, because I always often send people home the day of surgery. I always tell people, hey, your significant other that just had a knee replacement, they're not handicapped, they're not disabled. If they want to get a glass of water, they can get on that walker, walk to the kitchen and get some water. That's part of the recovery. That's part of rehab as far as I'm concerned. But when I do send someone home straight from the surgery center 4 hours, after surgery, it definitely makes sense to have someone there with you, at least for the first night. You never know how you're going to react to anesthesia. You never know if, anything can happen. But I don't think you need someone waiting on you hand and foot for 4 weeks. And I tell people that. Now, I want to just kind of end on, well, I've been talking about knee replacements. I've been talking about here, but what are we even talking about here? What are they? So this is an x-ray of someone who's had both their hips replaced. These are not my x-rays per se. But what it is basically, I describe it as, hey, we take out the bad parts of the bone, we cut out the arthritis, and then we reshape the socket, and basically we'll replace the metal replace the bone with a combination of metal, plastic, and ceramic. Now, specifically, the metal is typically titanium, and that's because bone really grows well to titanium. These implants, what you see to the left, is kind of what I wanted you to correlate with what you're seeing to the x-ray on the right. There's typically 4 parts of that hip replacement working from the in to the out. It's that titanium or that metal socket, that piece of plastic liner, which isn't visible on x-ray, that new ball, which is typically ceramic, and then the stem that goes inside the bone. Now, there are a ton of ways to do this. You can go from the front or the anterior approach. You can go from the back of the hip, or we call the posterior approach. There are other approaches I didn't include. Those are the 2 most common. You can imagine if you can go from the front and if you can go from the back, then you can probably go from the side. But that's a bit of a less often used approach nowadays. And of course, how you do it, I'm a staunch believer in technology pretty much in all aspects of my life. And there's nowadays in 2025, we have great intraoperative technology where I think takes a lot of the guesswork out of some of the things that we used to kind of rely on more manual techniques. And these robotics, these computer navigations, they are very, very good. They help us eliminate issues such as leg length discrepancies. They help us eliminate real bad positioning of these implants when you're relying on more manual techniques. And I would recommend, if you want to get something done, probably go to someone that uses some type of technology in the operating room. Now, I love doing hip replacements. It's my favorite surgery, and not necessarily because it's so fun during those 45 minutes. It is, but it really is because these are my happiest patients. I think these are some of the happiest patients we have in medicine. And the Lancet is a very high impact medical journal. This is not an orthopedic journal like the Journal of Arthroplasty or the Journal of Bone and Joint Surgery. This is a medical journal. And in 2007, they came out with a review. A lot of these authors in this are people that see our patients in the primary care or the internal medicine setting, and they made it very clear, the operation of the century, total hip replacement. And I make sure I mention this to all of my buddies that are in different fields, whether different fields of orthopedics or different fields of surgery, to say, hey, you guys are just doing inadequate surgeries because we're doing the operation of the century. And why that's the case is because people do so well. I think if you look at the studies, you're going to get different numbers, but the general trend is about 95% of people say their hip feels better. It is rare, and I think this is going to be a sentiment echoed by most of my partners here. I don't see a lot of people 4 weeks after surgery that aren't telling me their new hip is way better than their old hip. In fact, what often happens is I say, hey, how's your new hip compared to your old hip? Again, I'm talking about just 4 weeks after surgery. And a lot of my patients just scoff at the question, like, oh, are you kidding me? It's not even close. And they're barely in their recovery. Only about 5 to 8% of people afterwards are quote unquote dissatisfied. And this is the surgery where people look at me and they say, Dr. G, I don't know what I was waiting on. I didn't play golf the last 4 summers because my hip was bad. And now I feel like I got some catching up to do. And I wish I would have gotten this done sooner, because this is really the operation of the century. Now, how I do my hip replacements, just to give you a little bit of information on me, is I do utilize the anterior approach. I'm a believer in the approach. I think the data shows that you do have a lot of benefit when it comes to, obviously, a little bit of an easier recovery in the beginning. You're working kind of in between muscle planes. You're not really disconnecting some of the muscle and tendons from the back of the femur and some of the other approaches. And you're not cutting through muscle like you are on the lateral approach. And it does have a less risk of dislocation, particularly compared to the posterior approach. I use robotics as well as computer navigation. And that's kind of what this somewhat blurry screenshot is. Back to what I mentioned, the technology. When we do these hip replacements, a lot of people are worried about, are my legs going to be even? Are my legs going to be short? And this is telling us, when I do this, exactly how much I lengthen someone's leg. And this number that you see in the box to the left is the leg length. The number to the right is what we call offset. I'm not going to get into that. But, I have a plan for patients. I say, hey, my goal is to basically bring your hip back to where it was before you lost all that cartilage. Usually that's somewhere between 2 to 4 millimeters. We run the numbers on the computer. This is all in the operating room. And it tells us, hey, Dr. G, you've lengthened this person by 2 millimeters. I say, great, that was my plan. Let's put the final parts in, we're done. Now, if I trial and get a number that says, oh, Dr. G, you lengthened this person 8 millimeters, and my plan was 2, then great, I've caught that in the middle of the operating room. I make my adjustments, I recheck those numbers, and I get it to what I want it to be, and then the final parts go in. And, these are really, I think we've gotten really good. We've gotten really fast and efficient on how we do hip replacements, especially for people who are like me, that's all they do. It takes about 45 minutes. A lot of these hip replacements, quite frankly, take closer to 30. You're up walking an hour after surgery. There are no precautions. What we call precautions are basically don't move your hip in XYZ position. That was really the mainstay of the posterior approach, where people couldn't flex their hip up past 70 degrees. They'd have to have elevated toilet seats at their home, but we don't really worry about that as much with the anterior approach. And then you do have stitches under the skin, surgical glue, waterproof dressing. You shower like normal. If you don't have a high risk of blood clot, you just take a baby aspirin twice a day for 30 days. Now, quickly, knee replacements are basically the same general concept of you're retreading the tire. You do take a little bit less bone with a knee replacement. The way I describe it is, imagine the tile of the floor is getting really worn down. You don't throw away the whole building. You just strip off that layer, put a new layer. And that's what we're doing, is we cap off. We take a small amount of, roughly about a centimeter of bone. What we take off with the saw, we cap back with a piece of metal. And the reason why these 2 pieces of metal aren't touching here is because there's a piece of plastic between the 2. Now, knee replacements also do well. Now, not quite as well as hip replacements. No one has called the knee replacement the operation of the century, unfortunately. But again, 90% of people are much better from a pain and function standpoint. And I think it's about 4 out of 5 or 80% are better and satisfied. But that dissatisfaction, about 5 to 8% for the hips, is closer to about 15 to 20% for the knee. So maybe about 1 out of every 5. Now, the way I do them is I cut off a little bit at the bottom, but I do try to do a less invasive approach. You can see kind of the top right. This is a rather large leg here, and I have a ruler. You can't see, but it's about a 3.5 inch incision. I see, you may see a lot of people in the community have kind of a scar from the mid aspect of their thigh to the mid aspect of their shin bone. I don't do that. I make it as small as I can to do the surgery safely. I do these almost always with robotic assistance. And that means as we get a CT scan, from that CT scan, we actually build a 3D model of your knee. And that lets us know exactly the right position, orientation, and everything for your anatomy. And what you're seeing in the bottom right is exactly what I do before every surgery. Is I review that CT plan, I look at the model, I look at the parts, and we fine tune this based on what we find out in the operating room when I test your ligaments, when I test your motion. And it does make a little bit more of a personalized knee replacement. Similar to the hips, it doesn't take that much more than 45 minutes, 30 to 45 minutes. Same protocol, weight bearing, motion is tolerated, stitches under the skin, surgical glue, waterproof dressing. About 2/3, probably to 3/4 of my patients go home the same day, the same blood clot prevention protocol. So just to kind of wrap up here, the main takeaways is hip and knee osteoarthritis. I mean, they're as common as the sky is blue. You're not alone in having this issue. I'm sure a lot of people have support in the community. I am a believer that surgery is the last option because it's like putting the toothpaste back in the tube. You just can't do it. So it should be really thoughtful in making that decision. But for the right patient at the right time, these are truly life-changing surgeries. And I have really sweet patients that feel like they have to give me gifts because of what I've done for them, which they absolutely do not. But it does show me how much they appreciate that this is something that has really affected them in a positive light. Now, deciding when, of course, involves balancing a lot of factors, and it just should start between a conversation with you and your potential surgeon. This is your body. This is your health. Advocate for yourself. If you feel as if your surgeon isn't hearing you, is treating you like another number on the wall and not really personalizing their care and their message to your needs, to your goals, to your activities, there's a lot of other surgeons around. I recommend getting a different opinion. All right. Now, I think that's about what I have for you today. I do have some questions I want to go through here that we got from the Facebook Live. So I'll just start at the top. One of the questions I got are one of the most frequent or major complications. So knees and hips are a little different. So hips, we do worry about things like dislocations, which is not really a complication for knee replacements. When you mention major complications, the thing that we dread that is the bane of a joint replacement surgeon's existence are infections, or what we call prosthetic joint infections. Those are not very common. They're about maybe 1% for the hips, 1.5% for the knees. But most frequently for the knees, you're going to get less major complications, more likely to have things like stiffness, dissatisfaction for those reasons. A lot of what you'd see the other, minor complications for the hip, like leg length discrepancies, we just don't really see that nowadays, at least in the way we do hips around here. So when I have a patient says, what is a realistic expectation for my pain and mobility improvement after recovery? Well, it's hard for me, I think, to answer that blanket because everyone's different. That's what I mean kind of by this personalized approach, is that if for me to best answer that question, I want to sit down with you and say, hey, what do you do now? What have you done in the past? What can't you do now? What do you want to get back into doing? It is true. I've had some patients that, the weekend warrior types who come to me because their knee starts hurting on mile 20 of the marathon. That's not something a knee replacement is really meant for. And that's a very different scenario than someone who can't walk to the mailbox. So this is really a personalized thing. Now, how can I prepare my home to make it safer and easier for me to get around after surgery? That's a great question. So, things that are just not safe in general around the home, rugs, mats, those things can roll up, they can bunch up, and those are fall risks. And I would say that's a general rule, not even necessarily related to post-surgery. After these hip and knee replacements, I tell patients, you're going to be able to walk, you're going to be able to get around, you're going to be able to do stairs. Now, are you going to be going up and down stairs like a madman the day after surgery? No. So you're going to be a little bit more economized in your motion. If I'm going to go upstairs, I'm going to take my time. I'm going to grab everything from upstairs and then come back down. But you are not going to need to rearrange your house from head to toe as if someone with a massive wheelchair is going to be there for the next 8 months. How long will it last? That's a great question. I think the modern day implants, I typically tell people, and it depends on how we put them in, your age, your bone quality. Do we put cement? Do we not put in cement? But I try to tell people, I feel confident that for the most part, it should last somewhere in the 20 to 30 year range. That depends on, like I said, the aforementioned factors. A lot of the current generation of really high-end, technologically savvy, well-engineered joint replacements, quite frankly, haven't been around for 30 years for me to quote things like 30-year survival from the data. But, unless I'm operating on someone who's in their 30s, 40s, I feel fairly confident there's a much higher chance than not this is going to last the rest of your life. And the last one I got is, what is the difference between traditional and minimally invasive surgery? That's a great question. So I think, let me speak specifically for me. Minimally invasive, I think, is a hot button word. I think certain people use it in ways that don't make sense. When I mention I do minimally invasive knee replacements, I do it in a couple ways. One, I typically don't cut that tendon that powers the knee, and that's the quadriceps tendon. What I do is a small slit in the muscle that's called the mid vastus that allows me to kind of have a little bit of a smaller incision and makes it a little bit easier to kind of straighten that leg after surgery because I'm not violating kind of the tendon that powers the knee. Now, it's not necessarily going to mean your knee replacement at 4 months is way better than the traditional way, but I do think it does have some early advantages. I tell people that the scar is only part of the minimally invasive way, and it's really how you treat the soft tissues below. Back when we talk about the hip, I think the anterior approach, especially if you're very gentle and respectful of the soft tissues, you can do it in a way where you really don't disrupt the muscles that much. I do think that's less likely to happen from the posterior approach, where by nature of the surgery, you have to detach some of the muscles from the bone. And with the anterior approach, it does allow us to do this in a way where we can be really much more friendly to the tissues. And to me, that's what makes something minimally invasive, not just the size of the incision. So I think those are the questions I have. I think we're a little over time, but I'd like to thank everyone who spent time to sit with us today, learn. And of course, this will be a video that'll be online for anyone to reference. You can share with all of your family members, anyone who's interested in hearing about joint replacement. As you can see, this is all of our information. We have a lot of offices. We have a great team. And this Anderson Clinic is world-renowned for a reason. It's because we administer the highest level of patient care, and we put patients first.